the recording now, and so just be aware that if you ask a question, just I won't be able to hear you. So if you could just make sure that you, like I covered just a moment ago, through chat or through the questions. So that being said, let's go ahead and get started. I did want to find out, before I plow into what I'm going to cover today, I did want to find out a little bit about the attendees today. And, I see that, let's see here. I see some names that I'm very familiar with, and I see some new names. So I wanted to find out, through the chat box, is there anybody that this is like their first time being exposed to a sleep education or a Bruxism education? Or, is this the first kind of thing that you've done regarding learning about sleep and Bruxism? And I'd love to find out if that's the case. I do change a little bit about how I talk if there's a new individual on board. On the bullet 2 here on the slide, I do want to emphasize that we are very interested in interaction, and I just want to make sure that if you do have a question, don't be shy about asking it, because I guarantee you if you have a question, someone else has the same or similar question, and it helps the whole group by having an interaction rather than me just talking about what I've learned. I've already mentioned a couple times that the session will be recorded and it will be available on demand listening in a couple of days. And finally, I did want to mention that DDME and WIPMIX, we do like to spend some time one-on-one with individuals, kind of going into a little bit more detail on what we do and find out the level of interest if there's anybody new to the program and want to learn how to get started. So if you're interested in a one-on-one session, I invite you to let us know that through the chat. I'll provide my phone number, 951-496-6126, and that'll be up the last slide as well. Give me a call, shoot me an email, and say, geez, Jeff, I was a little bit interesting what you talked about. Can we schedule a one-on-one session? And I'd love to do that. That's one of the best things about what I do. So by all means, feel free to ask that. So let me talk about what we're going to go over today. Or we're going to talk about bruxism as a sleep disorder. Bruxism is actually a medical condition in the sense that there's a medical diagnostic code for it, and a lot of people are surprised by that. But we're going to talk about the implications of the fact that bruxism is a sleep disorder, but not necessarily addressed by the medical community. We're going to talk a little bit about the airway and bruxism and their interaction. We've done quite a number of our bruxism studies, and we're confident that there is a relationship there, and learning about the interaction has actually enabled us to take a much better swing at treating bruxism and even eliminating it in some cases. So we're going to talk about that. The meat of today's webinar, though, is going to talk about sleep apnea syndrome. And we don't use that SAS anymore, or not as much as we used to. I've been doing sleep studies for, well, a very, very long time. And when I first started, it was called sleep apnea syndrome. And I want to spend some time, because that cuts to the heart of the health consequences of unmanaged sleep disorders. And it's critical, and it represents a tragedy, and it also represents a tremendous opportunity, which is why I'm bringing it up. Bullet 4 is also, I'm going to talk about the potential side effects of single arch occlusal guards. So on bullet 2, I talked about the interaction between the airway and bruxism. Well, when you put an occlusal guard in, we've learned some interesting things there, and I'm going to share that with you. Number 5, I'm going to spend a little bit of time talking about the monitor we use that assesses the airway and bruxism, and we're going to talk about a novel approach to managing bruxism on bullet 6 using the BRX Pro. Okay, so that's what we're going to talk about today. Okay, so let's start off with bruxism is a major sleep disorder, and when I say major, the incidence of it in the population is number 5 most common sleep disorder. So there's insomnia. And insomnia, by the way, is on an order of magnitude the most common. The next one we can probably all guess is sleep apnea. There's limb movements, and then there's parasomnias, and then there's bruxism. Bruxism is a movement disorder, and it's coded as such in the medical CPT code. It is not a seizure disorder, and I say that because there's so much mystery surrounding certain aspects of bruxism that sometimes people just say, well, it just happens, and actually we can explain the triggers on almost all types of bruxism. And I had a very interesting conversation today with some academics on the East Coast about how we know when a person's swallowing while they sleep versus a clench or a grind. We can very easily distinguish between the two, and there are some academics on the East Coast that were very interested in that capability. But getting back to the heart of the matter, bruxism is very common in the population. As dentists, we know this. It is a sleep disorder, a medical condition that is only managed by dentists and essentially ignored by the medical community. And the little box there on the bottom is a quote from the Mayo Clinic website, which indicates, yes, bruxism is a sleep-related movement disorder. That's not new information. But what I do like about that comment is that they do associate it with other conditions. So it's not a standalone problem. It is tied to other problems, and if we manage some of those other issues, then perhaps we can manage bruxism as well. Okay. All right. So let's first talk about the link between the airway and bruxism. I like this slide that you're looking at. This is a slide, this is information put together by Dr. Simmons and Ron Pren, a neurologist and a dentist, working down in Houston, done some great work on identifying the triggers of bruxism. And they do it in a way that they use a special, it's called a PES manometer. It measures the very subtle airway changes. And when you line up those airway changes with bruxism, you can see that one precedes the other. And hence, there's convincing evidence that a clench and a grind is a protective mechanism to restore the airway to normalcy. So that's a fairly well accepted theory, and there's a lot of kind of sub-theories around that, but at the end of the day, most clenching and grinding is an effort to restore the airway. Okay, so let's talk about that concept a little bit and the implications that that concept has in dentistry. Okay, so the study that you're looking at now is a pilot study. It's fairly common for us to cite this paper. It's not a strong paper, but it's one of the only ones we have. And so we do cite it quite a bit. And it's what happens when you put a single arch guard in a sleep apneic. Okay, so a person would never, the medical community would never do that. So this was done by dentists to see what happens to the airway when you have a known bad airway, or somebody who's been diagnosed with sleep apnea, I should say, and you put a single arch guard in, and you can see on these two columns, there's the baseline on the left and the splint on the right, and you can see all of those data points on the right are essentially higher than the ones on the left, and which indicates that the splint introduces a new risk to an already compromised airway. So if you have apnea and you put a splint in, it's likely that that apnea is going to become worse. Okay? So more study needs to be done in this area, but that's fairly convincing, convincing evidence. The next slide I'm going to show you here is another way to convince us that bruxism is related to the airway. And this is a study that's not too old. It's about, it's 12 years old. And it's not as well known as maybe it should be based on its importance. And the essence of this study is they had patients that were diagnosed to have bruxism, and the bruxism was assessed using a full PSG, and then they treated those patients with CPAP, and then while they were fully treated with CPAP, they went back and and did another diagnostic test to see how much bruxism was remained once the airway was managed, and essentially the bruxism was eliminated. And so what we found is when you treat the airway, bruxism seems to go away based on the results of the study. So that's just further support to the idea that bruxism can be managed, and it can be managed actually very well. I wanted to show you, before I get too far into this, I wanted to show you what a normal sleep looks like. So what we're doing, what you're looking at right now is about 5 minutes of sleep. And I'm not going to go in, I don't want to teach what you're looking at, but I do want you to observe how much synchrony and flat lines there are. So you can see a lot of synchronous waves going, and that's the effort and the airflow and so on and so forth. The oximetry is flat, there's no desats, there's very slight heart rate fluctuations. You can hear the breathing there on the bottom channel. There's no bruxism going on. There's a flat line on the bruxism channel. This is a good 5 minutes of sleep. This is what we would all like to be getting all night long. Okay? So imagine, the next slide, that this is going on. Same patient on their back, and when you compare this to what we were just looking at, it's a world of difference. And the reason that I'm showing you this is because I want to make sure that everyone understands this goes on whether you are aware of it or not. And the reason that I'm telling you this is because if this is happening with your patient and you don't know it and you're trying to do something with your patient, anything, restore, create a bridge, implant, whatever it is that you're doing. Imagine this going on, you not knowing it. What do you think your chances of success are? Probably not great. And so what I'm emphasizing here is, in dentistry, we really do care about what's going on when you sleep, and whether or not the airway is healthy or not. Even if you don't want to treat sleep apnea, okay, even if that's not on your radar and you never want to do that, and you don't believe dentists should be doing that, like some don't. However, if you're a dentist and you're going to make a bridge, or you're going to do some edentulous work, and this is happening and you don't know it, you're in for a bunch of grief. So it would be good for you to know that this is going on, okay? All right, so that, having said that, I want to kind of shift gears a little bit. I'm checking for questions here. Doesn't look like we have any yet, okay? When I talk about airway, there's a reason I use that term, because, and I'll tell you the reason. The link between bruxism and the airway is much stronger than bruxism and sleep apnea. Okay, so let me clarify that, because if you're not real familiar with the difference between some of these terms, it sounds like I just said the same thing twice, and I didn't. So let me explain to you what I mean. Bruxism is triggered by any type of airway issue. It could be a little bit of snoring, a little bit of crescendo snoring, and then the bruxism occurs. Okay, the active mechanism that's causing that bruxism to occur is the CNS response, or an arousal, as a result of the body sensing there's an airway issue. So what happens here is any airway issue can cause a clench or a grind, not just an apnea or hypopnea. Okay. Moreover, what we see at DDME and WhipMix is the fact that it seems like the earlier a person is in the apnea disease state, the more sensitive the CNS response is. Okay, so what that means is, if you're just starting snoring, your body's going to be very sensitive to problems and react very quickly to the problems to restore the airway. 10 years from now, your body's not going to be clenching and grinding every time you snore, because that's just not how it works. So what we find is, as dentists, when you catch this early, not only can you prevent tooth destruction because you kind of circumvent the triggers, and we'll talk about that at the end, but think of the health consequences of catching somebody when they're in the early stages of this and they don't go down the sleep apnea path for years and years and years. Think about that for a second. Think about the health benefits of that. Now, you're not necessarily tackling the medical condition of sleep apnea. You're interested in protecting your patient's teeth. And in doing so, you want to figure out, okay, what's triggering this? Is it snoring? Is it frank sleep apnea or something in between? And when you identify the issue, no matter how you manage it, it could be that you send them off to a sleep lab. However, whatever the outcome is, when you intervene earlier on sleep apnea, it has tremendous health benefits on the upside. Okay, so that's one of the main reason that I talk about airway rather than sleep apnea, because there's airway events that fall outside sleep apnea, and so we'll talk about those here in just a second. So can you effectively, and then as a dentist, you know, if you're going to be measuring your patients, you do need to know that there are certain types of apnea that there's absolutely nothing as a dentist that you can do about it. And that's primarily central apnea, complex apnea. And those are conditions, medical comorbidities or signs of medical comorbidities that do need to be addressed, but not by a dentist. Okay, so the good news is if you detect that, let's say that you pick up complex sleep apnea and you say, oh geez, let's get you to your physician and let's give them this report because we've identified an issue. You've done your patient a great service. Okay, so that wasn't necessarily your intended outcome, but let me give you a correlate to that. Let's say that you have a cone beam and you do a cone beam on your patient and you see a spot in their jaw or in their mandible. And it's not the type of spot that's a dental issue. It's some type of, it could be sign of a tumor or some type of growth. Okay, now as a dentist, you're obviously not going to take that on, but you're going to refer that patient to somebody that can assess the problem with a little more detail than you could. Okay, now is that a bummer? Obviously, it's not. In fact, it's a tremendous benefit to your patient. And the same thing, if you take a measurement on a patient and you find that they have complex or central sleep apnea, that's not a bummer in any stretch of the imagination. It's a great thing for your patient. The next bullet there. Can you effectively detect upper airway resistance? Now, the reason that I'm asking that question is, I talked about the airway and the difference between sleep apnea and the airway. One of the most common triggers of clenching and grinding is upper airway resistance. Okay. Now, let me tell you something sad about upper airway resistance. It's not covered by medical insurance. And so what impact does that have? The fact that you can't be treated and that the treatment isn't reimbursed by medical insurance, what impact does that have? Well, in the medical community, if you're not going to get paid, it's difficult for them to manage a problem because essentially it's going to come out of the patient's own pocket. So upper airway resistance does not get the credit it deserves on the compared to the impact it has on patients, simply because insurance doesn't pay for its treatment. Okay, does that have any impact on its clinical consequences? Of course not. But it's there, that's the facts, and as dentists, you can pick this up early and we can figure out much better ways to manage it as opposed to just ignoring it. Same thing is true with RERAs, respiratory effort related arousals. So when you add up apneas, hypopneas, complex sleep apneas, and then the upper airway and RERAs, all that becomes what we call airway, okay? And some of the things that we detect you can manage, most of them you can, and other things you can't. And at DDME and WITMIX, we're actually part of what we do for our dentists is we keep you out of trouble by triaging these patients that can be helped and those that need to be referred out. So we do spend quite a bit of time with our dentists helping out. So it looks like there's a question there. And let me see who has that question. Just give me a quick second here. Maybe not. Let's see here. Okay. Okay, sorry about that. Okay, so what we're going to do next is we're going to talk about, I'm going to spend a little bit of time talking about kind of the mechanics of the airway and what happens to an airway that's kind of going downhill. Okay, so there's a slide here that I'm showing you that actually that goes through. I love this. This is let's see, about 3 minutes of data, 2.5 minutes of data, and it's a beautiful example of an airway that starts good and just starts to go south. Okay, so looks like Amy's got a question. Um, Amy, if you wouldn't mind just typing your question in chat for me, um, and that way I can help you out. Okay. Um, I just don't have the ability to hear anybody today. Okay, so on this airway slide, what we're looking at here is on number one, where it shows kind of the little orange boxes, and then it says number one flow limitation. The monitor that we use, the Bruxism monitor, has a cannula, and there's when we plot the flow signal, when there's a little bit of flat signal on the top, that means that there's resistance in the upper airway. Okay, so resistance in the upper airway in of itself isn't all that big a deal. When it becomes a big deal is when it causes other responses. You know, that's when we care about it. Okay, so if you look at this, if you look at the very bottom of that, there's not a lot going on the first 6 or 8 of those flow limitations. And then if you look at the last 4, if you can see the bottom channel, you see those spikes, those red spikes, that the patient starts to snore. So what's happened here is as a result of flow limitation, there's a little bit of negative pressure in the airway, and that negative pressure has drawn in or compromised the airway, and the patient starts to snore. Okay, so you can see a series of snoring, and the snoring is getting louder and louder because you can see the spikes are getting higher and higher as it progresses. And then what you start to see is, 5 or 6 spikes from the end, you can see that the patient starts to have a hypopnea. And at the same time, just above those spikes at the snoring, there's a little channel there that we call it rip phase, and you can see this orange bar. And I know that you probably can't read it, but what it says on that orange bar just above those spikes is paradoxical breathing. What that means is the patient's having to work really hard to draw in air. Okay, so we're seeing a tremendous increase in work of breathing. So what's happened now is the snoring is getting to the point where the patient's having to work hard to breathe, and we've now graduated into number 4, which is a hypopnea. A lot of us know what hypopnea is. It's a percent reduction in flow coupled with an oxygen desaturation of 3 or 4%, depending on who you talk to and what your protocol is for counting hypopneas. But in essence, the flow is restricted. The patient's not getting enough oxygen to the tissue, and as a result, the blood oxygen level starts to drop, and we can see that in that green line there. Okay, so now we have this hypopnea going on, this oxygen desaturation. One of the interesting things that happens when your blood oxygen level starts to drop, your heart rate drops, which is counterintuitive because you think, okay, if I'm holding my breath, my heart rate's going to go up. Well, in response to the blood oxygen level dropping, the heart slows down for the purpose of trying to conserve what oxygen has left. Okay, so we call that bradycardia. So if you've ever heard the term bradytachycardia, we're in the bradycardia part of that. Okay, so the heart rate slows down in an effort to save whatever little bit the oxygen that we have left. Okay, so then what happens, you can see at the very end of this event, number 6, there's a clench and a grind and kind of this big heave and breakthrough breathing. So we see this at the very end of this epic. You can see a lot of changes. You can see the excuse me. You can see the snoring stopped. You can see just above the snoring, I'll draw your attention to the respiratory effort goes down to normal. The reason it went down to normal is because we clenched, we popped open the airway, and we don't have that resistance in the airway any longer. Okay, so the clench worked. All right, so this is what happens over and over and over again. Now, let me make one more point about this slide. One of the things that's interesting is when you catch somebody in the early phases of the sleep disorder, what'll happen is that clench that you see at the very end of this epic, that clench will occur way over here like where number 3 is. So you have that flow limitation, and you'll see a clench. And we see that a lot in women. Women tend to have a lot of upper airway resistance or flow limitation and clenching. Okay? They don't progress to the right half or the second half of this epic. They're not there yet. So as a dentist, if you detect flow limitation and clenching and you intervene, the patient, and you're successful at treating that, the patient never has to go through the grief of years of apnea. Okay, so that's a great thing. Okay, but getting back to how this progresses, as the years march on, that clench occurs later and later and later, and then we see, sadly, people that have very severe sleep apnea, they don't even clench. In fact, I'll show you some amazing cases of people that have just life-threatening apnea, and their heart rate doesn't even change. I mean, imagine that. I mean, that's somebody who has had sleep apnea for a long time, and I'll show you that here in just a bit. Okay, let's see here, just checking questions. Okay, Amy, is sleep bruxism treatment reimbursable by medical insurance? If so, who can? No, medical insurance will diagnose you but won't pay for therapy. However, depending on the treatment, medical insurance will pay for treatment. Okay? So let me explain, let me put a little more information on that answer. So if you detect bruxism and you do a test for bruxism and it turns out that your patient has sleep apnea, okay? So then what you do is you diagnose your patient with sleep apnea, and depending on what the physician decides to do, because physicians can only diagnose apnea, not dentists, and I know you guys know that. And to be honest with you, there's a lot of people that talk about how dentists shouldn't be doing this or that. I really don't know of any dentist that's running around diagnosing people with sleep apnea. I just don't see it. However, if you're looking for bruxism and you see sleep apnea, you send your patient down the apnea path. Okay, now that could be that we have a physician at DDME. I mean, we can diagnose your patients for you. We have physicians that do that on staff. If you send them to a sleep lab, the sleep lab will diagnose them for you. And then the physician will say, oh, I think the patient should do this. You sit down, or the physician sits down with the patient and says, let's discuss your treatment options. And if it happens to be an oral appliance, you get that patient back. Okay? So now that treatment is reimbursable by medical insurance. Okay? However, just another word of caution to be a little bit careful. The physician decides that the oral appliance is appropriate, not the dentist. Okay? And then the dentist sits down with the patient, or the physician sits down with the patient and says, here's your treatment options. We can do CPAP, we can do oral appliance, we can do surgery. And cases like yours, typically an oral appliance and mild is the best thing to do, simply because it's better tolerated most of the time by people. In your case, it's mild, and it will be just a little more comfortable. Or it might go that you have moderate to severe sleep apnea, and because of that, we really do need to be a little bit aggressive. Let's get you on CPAP. Okay. In that case, obviously, the patient's going to end up on CPAP, and you're not going to be involved in the treatment of that. But in the case where it's an oral appliance, absolutely will. And Amy, you can get paid by medical insurance for that. In fact, I'll tell you, I'll give you a little plug on our next webinar. It's going to be on how to get paid by medical insurance for treating patients with sleep apnea. Okay? So it sounds like you might be very interested in that one. Okay. This slide here, I'm going to kind of skip over. It's simply because it lists exactly what I've been talking about with regards to detecting upper airway resistance, UARS, upper airway resistance syndrome, and RERAS, which is respiratory effort related arousals. And these two are kind of related problems, and as a result, it disturbs the patient's sleep. These conditions are as severe or have as severe or serious health consequences as frank sleep apnea. However, if they only have upper airway resistance or RERAS, medical insurance doesn't pay for therapy of that. So we like, that is kind of the downside. Okay. All right. Let's talk about flow limitation for just a second. Flow limitation is essentially when you are inhaling. At the peak of your inhale, you're putting a little bit of negative pressure, because anytime you suck in on a tube, that you draw in pressure on the tube. So this is what triggers the risk in the airway when you're breathing in. And when you see on this patient, you can see the top of the waveform based on the normal breath on the left compared to the flow limited breath that's just flat at the top. That flatness is caused by the airway in some area has restricted the flow, or made the flow less available, and as a result we didn't get the same volume. So essentially the volume of air that you brought in is reduced, and if you do that enough, you get to a hypopnea. And if you have enough volume decrease, you're not getting enough oxygen, and that's why you get oxygen desaturation. It's that simple. So this is really early in the problem, and this is the beginning of what happens down the road with people that have sleep apnea. So that's flow limitation. The monitor that we use analyzes every single breath for this. It's great. And when we see percentages of it in the presence of a normal AHI and a patient with symptoms, oftentimes sleep labs will say, sorry, you seem to be normal. Your AHI is 3, but the flow limitation might be 20%. Okay, well, in the presence of an AHI of 3 and a flow limitation of 20%, that's a problem, and it's an airway issue. It's not sleep apnea, but it's an airway issue and can be treated. Okay? All right, let's talk about this next slide. This is another example of flow limitation and causing increased work of breathing. I'm not going to spend too much time on that. I will say that every study that we record has this analysis done on it. Okay. All right. So let's talk about this slide. This is a slide that sleep labs love. This is the thing that they do really well, and that's detect sleep apnea. And you can see, if you remember the slides a few minutes ago, and it was like there was flow limitation, then there was snoring, then there was increased work of breathing, hypopnea, and then everything ended with the clench. Same thing here, but you can see here that this patient's farther down the road, and so what happens is their airway just closes. There's no flow limitation. There's no snoring. You can see on the bottom channel, in this particular case, that bottom channel is blue. This patient doesn't snore. You have to have flow to snore. There has to be a column of air passing through the soft tissue, and the soft tissue vibrates, and that's snoring. This patient, the airway closes. Okay, and it closes here for, looks like 37 seconds. All right? So we have absolutely no flow for 37 seconds, and look what the very elegant restoration mechanism, which is a clench. Look at what that did. It totally restored the airway, and it did a great job of doing it, I might add. The problem is we're destroying the teeth. Okay, so the crux of the matter is, as dentists, you do care about this, because in an effort to, restore the airway, there's a consequence here, and we're causing damage to the teeth, and that's why we're at this webinar today, to be honest with you. Okay. All right. Now let's talk about sleep apnea syndrome. All right. Let's see. We have another question here. Let me take a pause here. Follow-up question from Amy. Great. If they do not yet have apnea, okay, you're asking some good questions, Amy. These are okay. So here's the question. Amy's question is driving at, okay, no one's going to get paid. I should say it that way. Insurance isn't going to pay. So if the patient doesn't have sleep apnea, medical insurance, if their AHI is below 5 and you can't diagnose sleep apnea, medical insurance isn't going to pay for treatment. Okay, so that has an impact, and Amy wants to know what that impact is. Okay, the impact is Depending on the treatment that's done, well, really not depending, okay, you just have to decide what can the patient afford, all right? I mean, it sounds a little bit blunt and cold, but at the end of the day, the patient's going to be writing a check for whatever they get treated, whatever the treatment is. So that may have an impact on what you do. So if the patient has upper airway or flow limitation problems and they have damaged teeth, we need to intervene. One of the options that we're going to talk about here in a little bit is called the BRX Pro, which is an inexpensive transitional bruxism guard that actually manages the airway. It's a hold forward mandibular splint, meaning it's not a titrating splint like a Sonvident or a Narval or Tap Elite 3, but when the patient goes to sleep, it just prevents the mandible from going back in the airway. We're not really using it to titrate. The goal of the BRX Pro is to keep the airway in a healthy position while we're protecting the teeth. So that becomes an option when insurance isn't available. Okay, so that's a great question, Amy, and it deserves more time than I gave it, but we don't have it on our 1-hour webinar today. But maybe I'll invite you to schedule a webinar and we can go through and talk about some of these great questions in detail. Okay, so let's get back to the slide here, sleep apnea syndrome. And I just, it's a term that you don't hear anymore, but I like to, when I talk about health consequences, I like to use the term syndrome because it's such a foreboding word. And in this case, it's appropriate because sleep apnea is a chronic, insidious disease. Left untreated will take a tremendous toll on your patient. Okay, and that toll comes in the form of heart attacks, high blood pressure, congestive heart failure, on and on and on. We've all heard the health consequences and the comorbidities associated with sleep apnea. Okay, what I want to do is I want to kind of show you what that means, okay, and how you can intervene as a dentist. And I don't mean to imply that you're treating patients for a medical condition, but I'm telling you can identify these issues much, much earlier than they would have ordinarily been identified in the medical path, okay? So let me explain to you what I mean exactly by that, because it could be, I don't want it to be misinterpreted as you guys playing physician, okay, even though you could probably do a great job of it. When you assess your patient for bruxism, and let's say in the case that the patient is in the early stages, they have upper airway resistance, they're clenching, and there's some damage on their teeth. Because you notice the damage and you've gone to enough training to understand that that damage can be caused by an airway issue, and you do a test, okay, and you identify an issue early, and the airway issue early, okay, you prevent this whole path from occurring if you're successful at getting your patient treated early. Okay. Now think about again, this is the second time I've said I'm kind of repeating myself, but it's only because it's important. If you identify the issue early because you're wanting to protect your patient's teeth and want to prevent the cause of tooth destruction, which oftentimes is an airway problem, and you identify that airway problem 10 years before they even go to their doctor for it, just think of the upside to your patients on that. Just think about that for a second. And the opposite, let's say that you have a patient in your practice and they have a little bit of damage. You say, well, let's put you in a guard and you're on your way. I'm protecting your teeth. And as a dentist, that's my job, to protect your teeth. Okay. Now the patient, in the guard, we're going to talk about what guards do in a little bit. And I showed you that slide earlier about the research paper that shows that guards kind of introduce a risk to an already compromised airway. If you take that path, you're not taking advantage of this tremendous opportunity you have to help your patient. Okay, and the opportunity missed is that the patient goes down this sleep apnea syndrome path. Okay, their teeth are protected, but they're going down that path. Okay, and I don't want to sound preachy or condescending or anything like that. I just want to emphasize the opportunity that you have to help your patients, and it helps them by avoiding some of the things that I'm talking about now, because if you intervene early, they don't get congestive heart failure. They don't get Cheyne-Stokes respiration. Shannon and I at DDME, we see Cheyne-Stokes respiration all the time, and we have to get those patients to a cardiologist right away. It's too late. Damage has been done for those patients. Now, a lot of times they can be helped, but obviously these patients weren't intervened early enough, and the damage from sleep apnea took its toll over a long period of time, and now they have heart failure. Okay? And we can see heart failure when you do a monitor test. It's easy to see. It's obvious. And so, at the end of the day, we can prevent that. And if you don't take anything home from this webinar, take that you can help your patients with some of these problems. And I want to talk about the problem here put a little finer point on the specifics of what we're talking about. So we see those orange boxes right in the middle. Those are the sleep apneas, just like the one I showed you a minute ago, but here's a bunch of them in a row. And there's the oxygen desaturations to 82%. 82%. Okay? Imagine that, holding your breath, desatting to 82%, taking 3 breaths and doing the same thing again. Imagine that. Every night, all night. Okay? And then imagine the quality of life of this individual. By the way, this individual is a retired professional football player. And he didn't have a problem. He was nice enough to volunteer to try a new kind of appliance. That's the only reason we did a test on him. He was not wanting to get treated. And when I did the test, I said, stop the presses. This guy's really sick. And let me tell you what's not obvious here, and I'm going to point it out to you. This guy's desatting to 82%. His heart rate's not changing. His heart rate goes from 56 to 48. 8% change. He's desatting more than his heart rate changes. Okay, why is that? Well, remember when I said earlier that the CNS response starts to wear out over time? This is the final stages of the CNS. The system to try to restore the airway is essentially given up, and the apnea is completely having its way with this patient. I mean, it's just apnea owns this patient. I can tell you that looking at this, when your heart rate doesn't change and you're desatting to 82%, you need to call an ambulance and get to the hospital, because it's very, very serious. Okay? So this is the end stage. This is what I'm talking about. This is what you can prevent from happening to your patients. Okay? So that's enough about that. I'm going to skip this slide. This is talking about how you detect flow limitation and how easy it is. It couldn't be simpler. You just simply look at a number. What's the percent? If it's above 10% and the AHI is low, we need to dig in a little bit. Okay? In the presence of damaged teeth and high flow limitation percent, we pretty much know what's going on. And when you see that, you should say hip hip hooray. Let me tell you why. Because if you intervene and you manage the flow limitation and protect the teeth, guess what path they are not going to go down? That sleep apnea path we just talked about. Okay, you intervened early enough and you caught it. Okay, so this is the health consequences that you don't have to face because you as a dentist intervened early. All right, everyone's seen this slide somewhere. It shows normal breathing, snoring, apnea. Excuse me. The only reason that I put this up here is that I want you to know there's a scale on the AHI. 0 to 5, and you can't get, that's not diagnostic. So Amy asked about that. If you don't have apnea, when we say you don't have apnea, that means that your AHI is below 5. Okay. When it's 5 to 15, that's mild, and that's apneas and hypopneas per hour. When there is 15 to 30, that's moderate. Okay. So 15 to 30, that's the tricky one, because we're right in between. Should we do oral appliance as a physician? If you're diagnosing a patient and you're a physician sitting there looking at a patient whose AHI is, let's say, 21, okay? As a physician, that's a tough call. Even though that's moderate, you have to decide, okay, is this oral appliance? Is this CPAP? What should be my first recommendation? So depending on the physician, our physicians are very agnostic to therapy, meaning they're not predisposed to one or the other, all right? So, you know, a lot of times if sleep labs tend to be predisposed to CPAP. You know, most of us know this. Um, our physicians are saying, well, you know, it depends on other factors. And if CPAP is one, as far as the recommendation, oral appliance would be number two, or vice versa. And it just depends on what the particulars are in the case as to which direction the therapy recommendation goes on the moderate cases. On severe cases, they're going to get referred to a sleep lab for CPAP. Okay, that's just the common recommendation, and you're not going to get an argument from anybody except for the patient. The patient is to say, well, I came to a dentist, so I didn't have to do that. All right. So, and then the dentist does the test and hopes that they can fabricate the oral appliance, and they're severe. And so as a dentist, you got to sit there and say to your patient, well, you know, I know we were all hoping for an oral appliance, but you need CPAP, and you need to give it an honest, sincere effort, because the severity of your apnea is such that this is what you need to do. All right. I'm going to follow your progress on CPAP. Next time I clean your teeth, I'm going to ask you how you're doing on CPAP, but you need to try it. All right. It's unfortunate, but it's just the way it is. There's an oral appliance isn't appropriate for the first recommendation. Okay. Now, you see that patient 6 months later, and they say, you know, doc, I really did try CPAP. I tried it for a couple months. I got sores with pressure, what have you. I just can't deal with it. Then as a dentist, call the physician that recommended CPAP and have a conversation with that physician about this patient. Listen, physician, you know, your patient, your patient and the physician's patient, made a sincere attempt at CPAP and couldn't tolerate it. Can we try an oral appliance? And that physician will recommend oral appliance if you're successful at describing the situation and they believe it's appropriate. Then they'll write a prescription for an oral appliance, and you give oral appliance a try. You know, and that's how a severe patient can end up on an oral appliance. But it should never be automatic oral appliance, because that's just what the patient wants. Okay, that should, as a dentist, you know, I coach dentists quite a lot on this particular topic, and dentists should be CPAP advocates to the extreme. You do not want to be the dentist that's talking people out of CPAP. You do not want to be that person. Okay, so it could be that your patient was on CPAP and they can't tolerate it, and there's ways to handle that. But you don't want to be that dentist saying, you know, the oral appliance is more comfortable, and if you're not liking CPAP, let's try. You don't be that guy. Just don't go there. It's not worth it. Okay, and if the patient's non-compliant and an oral appliance is the second best option, it's better than nothing, then have at it, and you're taking the high road on that one. Okay. All right. Let me see if there's any questions here real quick. Let's see here. Looks like we're good there. Okay. Next slide. Okay, we're going to talk about how we do what we do in the dental office. Okay, so I've talked a lot about apnea, hypopnea, heart rate, oxygen desaturations, bruxism, clenching, grinding, you know, that type of thing, central apneas, all that stuff. How do we measure all that, and how do we simplify all that down to just a couple of phrases that enable you as a dentist to take the next step? Okay, so there's some technical requirements that we have. They're listed here. I'm not going to go through all the technical requirements. If you're really interested in it, I invite you to contact me, and let's schedule a webinar, and I'll go through the technical requirements with you. And as complicated as this slide makes it look, it couldn't be simpler. Okay, and one of the things that we pride ourselves on DDME is simplifying this to the extent that it can be simplified. You know, there's groups out there that say, don't need to think about it. Just look at the PDF and do what the PDF document says. Okay, we're not that group, but we do simplify it to the extent that you can make the good, responsible decision in the simplest way possible. Okay, and we do it through a fantastic instrument, the Bruxism monitor. It really is a phenomenal instrument. It has tremendous clinical capability, and it's really easy to use, a rare combination. Okay, so that's why I use the term high clinical yield. for how simple it is to use, you get a tremendous amount of data. Our tests are inexpensive. They're about $20 for supplies. And I would say 90% of our offices, the front office person manages the bulk of the program. And the chair time to the dentist is nominal, very nominal, okay? Okay, so let's talk about you decided. Let's just imagine we're testing, and this is kind of getting a little bit into what Amy was asking about earlier. The medical path. We have a very clear, very responsible, well-traveled medical path for dentists to take. So when you do a test and you want to treat your patients, we have a path for you. And what we like to do, I'm not going to go into the details of the medical path, but just know that you have access to the medical assets required by you as a dentist to have access to in order to treat patients with apnea. We provide that for you. Just know that. But one of the things I'm going to introduce, because I'm wrapping up here, we're coming to the end of a webinar, is one of the treatment tricks, and I call it a trick because a lot of people don't underestimate the value of this trick, and that is when you have a patient that's in your office and they are motivated to get treated, it's critical that you treat them at that point. In dentistry, you know that in other topics and other dental topics, the medical or the sleep apnea world doesn't really appreciate that. And it's evidenced by the fact, if you go to a sleep lab, they'll say, come back in 3 weeks when we can fit you in. That's our next opening. 3 weeks, I mean, we had 3 weeks, forget about that. No one's going to come back in 3 weeks. I mean, they do, but it introduces this gap in treatment initiation, introduces risks to compliance. And when I say introduce risks, I mean huge risks. If you talk about cancellation rates in sleep labs, it's very high. And that's because there's this delay, okay? When a patient's willing, that's when you as a clinician have to strike. So as a result of that, on number 3 here, after you do a test, send the patient home with a BRX Pro, and I'm going to talk about it in a second. There's almost any condition that the patient has, it's an inexpensive transitional therapy that will get your patient started. That cannot be overstated. You need to start when your patient's willing. Okay, if you say come back in 3 weeks when your appliance gets back from the dental lab, the patient may never show up. Okay, so you're sitting there with a fabricated appliance and the patient says, I changed my mind. Okay, so this is why we like to start treatment early. Obviously, this is a medical path. The implication there is the physician's involved, and actually with our path, 2 physicians are often involved. So we have a sleep specialist that diagnoses the problem. And then we always recommend that the patient's physician get involved so they're aware of what you're doing, and it's kind of a group effort, and we like to get a prescription from the patient's doctor, okay? So we have actually 2 physicians and a dentist involved in this whole process, right? And when you follow our process, it is billable by medical insurance, okay? This is a sample report from our physician. There's a couple key elements here. We talk about bruxism, specifics to it. This webinar is about the medical consequences of bruxism, and I haven't talked a lot about bruxism in of itself, and it's a little bit of a ploy in the sense that the medical consequences are of the sleep apnea, but bruxism is what initiated the test. All right. So we can report on bruxism on the report from the physician. We can talk about frequency and strength, and we'll talk about that in just a second. So this is the sample report. This is another sample report from a physician. And now I want to talk about the dental path. Okay, so as a dentist, you care about protecting teeth that are getting destroyed, and you want to do a good job of it. And is the single arch occlusal guard the best thing? A lot of times it's not. We talk about what guards can do to the airway, especially if your patient has a compromised airway. So the dental path, You do the same, you start the same. You talk to your patient, and as a result of that conversation, you order a test, you do a test, and you determine that the patient would benefit from therapy. So you address the dental issue, which is protecting the teeth. Use the BRX Pro. And the reason that I like to kind of promote the BRX Pro, it's the only guard that I'm aware of, occlusal guard, that has the task of not only protecting the teeth, but preventing the triggers of bruxism. Okay, so when you're wearing the BRX Pro, it keeps the mandible from going back into the airway, and it gives you a certain amount of vertical. So the combination of those two oftentimes resolves the triggers to bruxism. Okay, so then you do a second test wearing the BRX Pro and see where you end up. So if you have an airway problem and severe bruxism, you wear a BRX Pro and both are resolved, okay, you're done. And not only are you done, you've done a fantastic job, because not only have you protected the teeth, you've actually treated bruxism. Okay, and we have you can measure bruxism, and if it starts high and ends low, you've treated it, just like any other thing. Here's a sample of our dental report. It has a lot of information, and I will tell you the great feature of this is it's fairly easy to count clenches and grinds. Just the nature of that waveform is fairly easy to detect, and we do a great job of detecting. But what DDME found is that sometimes the frequency of clenching and grinding doesn't correlate well with the tooth damage that we see. So there was something going on that we weren't measuring, because you would expect if somebody has a high bruxism index, then you would expect that the teeth would be damaged, and sometimes you don't see that. And then conversely, people with relatively low frequency of bruxism had destroyed their teeth. So what we found is it's also the energy that the masseter expends. How hard are these clenches and grinds? And that information was not available. All right, so we had to create it. So we created a software algorithm. DDME with Whipmix have created this software algorithm that actually, in conjunction with frequency, also calculates strength. And we do it in a very clever way. We do a calibration, and we say to the patient, clench 5 times, and and then we measure those clenches, and then that's kind of the baseline unit, energy unit for the masseter, and then we add up all the clenches through the whole night, and we see that the energy expenditure of the masseter is much more correlated to tooth destruction than the frequency. Okay. All right. So I'm going to kind of cruise quickly through the monitor. That's what it looks like. I talked about how easy it is to use. There's the 4 steps there. You clip it to your shirt. There's a couple of effort belts. We talked about RERAs. We can measure RERAs because of those effort belts. The surface EMG on that little second picture there. A cannula for the flow, and then oximetry. And for those of you that might be interested in it, I'm getting asked this quite a bit. Is it a high resolution oximeter? The answer is yes. It's a very good oximeter. There's a download in the morning. So the patient goes home with that unit. They do those steps that I just showed you at home. In the morning, they bring it back. There's a download, and there's all this information for you to look at. And part of our training as we go over this with you, it takes about 2 hours, and you'll have plenty of expertise at that point to get started. Here's a triage report. The software that we use has about 20-something reports. This is one of those. We like this one. Actually, we created this report because it's summarized. It's a great summary report. It has the frequencies and the AHIs, the oxygen desaturation, the snoring, all that good stuff. Okay, so this is my favorite slide. All right, and I'll tell you why it's my favorite slide. It's my favorite slide because as a dentist, when you look at these, we're trained to, okay, here's what we do when we see this. Okay, and I want to add to that. So whatever you were trained to do when you see this, I want to add one more thing. And I want you to think, okay, this damage could likely be caused by an airway problem. And there's something I can do about that as a dentist. Okay, so the next time you sit down and you look into your patient's mouth, and it's like the first time, I want you to think about that. I want you to think about, okay, when I see this, okay, is this an airway issue? You know, what's going on here? And there's a really simple way to kind of sort through all this and figure out what's going on with your patient. Okay, just do a test, do a download, do the report. If you have any questions on that, call Shannon or myself, who are always available on the phone, and we'll sort it out with you. And it doesn't take 3 minutes. It's very simple. So when again, when you're looking at this type of tooth damage, I just want you to think about one more thing when you see that. This slide here is talking about the specifics of what happens to the airway in the presence of an occlusal guard, and I will tell you the AHI goes up. Okay, now when you put in an occlusal guard on a patient and the AHI goes up, you've protected the teeth but worsened the problem. All right, you've been warned. You now know this. Okay, there's a certain amount of responsibility now that you know this, that if the next time you make a guard and somebody's got damaged teeth, and maybe their BMI is 35 and their neck is 17.5 inches, you've been to a webinar that says, okay, wait a minute, a guard may not be the thing to do here. All right, because we see over and over again that everything gets worse in cases where a patient has apnea and damaged teeth, and you put a single arch guard in, you protect the teeth, but at great expense. And the great expense is that medical path I spent 20 minutes talking about, your patient's still on that. And do you really, as a dentist, I mean, honestly, is that an acceptable outcome? Okay, we're going to finish up with the BRX Pro. I already talked about the single arch guards. Most dentists avoid treating sleep apnea, and we know why that is. It's a hassle to get paid, and it's a little tricky. And there's this medical component. DDME's job is to kind of manage all those challenges to simplify the process for you. Okay, but there's this gap. From a single arch guard to a full-on sleep appliance, that's not even in the same planet with regards to what, as a dentist, you got to do. There had, at DDME, just like we created that software algorithm to measure strength, we felt that there was a product in the middle that was designed to treat bruxism without being a full sleep appliance. So we came up with the BRX Pro. It's a transitional appliance. It's made chairside. The reason we wanted to make it chairside is for the, my sleep apnea days. I worked in sleep labs for well over 20 years, and I know the importance of treating the patient when they're willing. So it had to be done, it had to be transitional and offered at the time that the patient's willing. It's partial arch. So we like the NTI, for what it is. It's been very successful. So we have a partial arch. It's adjustable, so depending on the class bite, when we say we need to hold the mandible in a comfortable spot so it doesn't go back, people's mandible, we all know, there's class bites, you just need to be able to put that mandible in a comfortable spot. So it's adjustable. And because we're preventing the mandible from going back, and we're offering about 4 millimeters of vertical, we're reducing the number or eliminating the number of triggers. Okay, we're stabilizing the airway, in essence, is what I'm talking about. Okay, this is the BRX Pro is essentially 2 partial arch trays, impression trays that have an interior hinge. Okay, you fill the trays with PVS, medium set, heavy set impression material. You trim it up, and you send it home with the patient. You pick the spot. There's 4 adjustment spots, so the pin can be reversed. So there's two positions, and then there's 2 slots on the mandibular tray. Okay. There's the instructions on picking your spot for the mandible. Here's some pictures of the impression inserts, I call them. So when you fill the tray with PVS material, you trim them up, and that's the pictures on the left. And then trimmed, that's a picture on the right. The BRX Pro is available in an acrylic version. It's actually talon material. It's coated in a softer material that you heat up when you fit your patient, and it fits. It's pretty easy to fit. And because it's partial arch, it's a little bulky, and it's very bulky if you're used to a single arch guard. It's not as bulky as an asleep appliance. It's kind of in between there. But because it's partial arch, it's not quite as cumbersome as some of the appliances out there. Okay. I'm going to just tell you that it works. We've done quite a number of studies using them, and it reduces the AHI and it reduces the EMG activity. Okay, and that's what these slides are talking about. And I am way over on my time. I just noticed I'm over. I really apologize about that. So wrapping up, again, there's my phone number. I gave it earlier. There's my email. It's jeff@ddmeonline.com. Send me an email and ask me a question, challenge what I said, request a webinar. I'd love to hear from you for whatever reason. But I do for sure want to end by thanking each and every one of you for joining us today, and invite you to our next webinar that we have. We have these every other week. And on the 22nd of January, we're going to be talking about medical billing. Okay? Thank you for joining me. And if you have any questions, I'm not going to hang up. I'm not going to end the webinar. So if you want to ask a question now, I'll keep the meeting open for a period of time. But I am going to stop the recording. Okay? All right. Thanks, guys. Appreciate it.